Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the podcast. This is Aebhric O'Kelly. This week, we are again with Zach Andrews, one of our Masters of Austere Critical Care graduates, who impressed us so much, we hired him on the spot. Zach, welcome back to the podcast.
Hey, Aebhric, thanks for having me on again.
So tell us a bit about yourself and what's keeping you busy.
Oh, I'm constantly working on some projects, a bunch of educational things, trying to finish up some projects for you guys and working with Phil also to try to do the student success department for the undergraduate programs and graduate programs. I always stay busy doing remote paramedicine here in Texas, and that's kind of always keeps me busy and learning and catches my eye. So that's how I stay relevant when I can't be out in the field like I want to.
So you've joined Phil Clark on the Student Success Department, which sounds like an SF mission because it's so vague. It could be just about anything. So tell us, what do you do there?
Yeah, my role there working with Phil is it's a bit different. It's a bridging role. It's a role where I'm not working for the professors, and I'm not necessarily working for the students either. I'm working for the best outcome of everyone who's going through there. So I guess the best way to put it there is I kind of bridge from the student body to the professor body. And I help kind of tie that together to make sure that both are meeting the needs of each other and understanding each other and the roles. And that's super broad within it. I wish I could kind of say that better, but it's making sure that the students are being challenged, which they may not want, but they need to become, as professional as possible, but also make sure that they're being enabled to reach that goal. And so it's a dynamic position where you kind of play on both sides of the line, and I really like it.
So you hit the ground running. You sent out a student satisfaction survey. What did you find out about our student programs?
The student programs, what came out of there is high value uh, and pertinent instruction. And so the students really like that this is a program that hits at medicine. That's its focus, and that's what they want. And they feel that it has high value into the field experience. Uh, and as clinicians, it grows them. And on the other side of that, too, though, there's also difficulties. COROM has a very unique approach to make school affordable. And it's not full of full-time staff. Everybody isn't sitting there, working in a building and with full classrooms and, teachers' aides and secretaries and all these things that make university so prohibitively expensive, especially, as we're going here in the U.S. And so because of that, there's a little bit of dynamic that the students have to learn and the college has to meet midway on within uh, being a bit of a self-starter with programs and maybe not having as much contact and direct instructions for everything, especially within that European mindset of, hey, we're giving you the baseline and we want you to explore past these topics and we want you to professionally grow as you're taking these courses. And so that's a bit of a challenge for a lot of students to get. Many countries, including the U.S., here in the U.S., we tell you exactly what we want you to know. In an undergraduate program, we don't care if you do any exploring. We actually would prefer you to just read and study purely what we're putting in front of you, which is good, but it makes you proficient, but it doesn't make you a student of the medicine. It just makes you it makes you regurgitate the medicine that was given to you. And so that's a difficult mind shift for students to pick up. And it took a minute for me too. It felt like you're going through school without a safety net. And so we're trying to find ways where we keep that great enhancement of learning, but also helping the students through that process and not feeling kind of out there alone in this sea of scholarly work.
I like the fact that all of our faculty are clinicians. They practice and they're not full-time with the college.
Yes, yeah, and it's incredible because it's relevant. You don't sit there and talk to somebody who said, "Well, I've read articles, so I'm up to date on medicine, but I've not done this in 15 years." You talk to them, and sometimes you get a reply email that says, "Hey, be patient with me. I'm out doing this work," and it's like, "What? That's kind of neat." Your relevancy is today, not years ago, which is common with a lot of programs you go into.
That allows us to not be overly expensive. I paid $35,000 for my master's degree in the US 20 years ago, and I got cross that it was that much and what I got from it. So by starting Quorum, I put into motion this whole concept of no one works full time at this point anyway, and everyone must be clinical.
Yeah, and that's what I think is the beauty of co-rom and the cost of school nowadays. We limit education purely by cost, and I compare my degree with co-rom to my brother's degree here in the US, and he got it's a master's of business, so it's a bit different, but it was again online. He never went in person at all, and I don't know the exact numbers, but it took him about 18 months to complete, and it was somewhere between 45 and $60,000, which is outrageous to think that that's what people are putting into 18 months worth of school.
Yeah, so charging 10,000 for our master's degree means that we don't have enough money to pay our faculty full time. But I want that because it forces them to also be clinicians.
Yeah, and I think, the faculty you end up getting, Um, it ends up not somebody just trying to to get them through from paycheck to paycheck and working a job because they want to, but you end up getting faculty that have a passion for this. As working with Phil Clark, I I receive no pay to do the student success, and I do it pure out of passion just because I want to help these other students who want the same thing that I wanted, a good quality education that focuses in the austere medicine realm that is affordable and applicable.
So, Zach, now that you're part of the student success department, what are your plans for improvement? How can we make Quorum better?
Yeah, so within the survey, there's a few tweakings that I found that we can do to our courses. And some of it's just a little bit more clear guidance and expectations. And I think all that work's going on right now. I know the bachelor's program had a big meeting to kinda level the wave tops and make sure that everyone's getting on the same page with that, and the other piece that we had too is just communication. I believe the staff side of the college, did a tremendous amount of work already and created, SOPs or protocols to align the communications better with students, and I know some of that went from multiple days before students would get replies to most of the replies now seem to be day of or next day, and including enrolling students much quicker and getting them set up much quicker than before.
Because of your feedback from your surveys, we have changed things on the back end anyway. And Chubba Diasegi, who is now our chief operations officer, has implemented changes for returning emails, for knowing where students are, and being better at some of the deficiencies that you found with your survey?
Yeah, he's done a fantastic job. I mean, he as a professor was great. I mean, he was clinically excellent, loved interaction with him, but his leadership abilities coming through, uh, was amazing. It was almost unexpected because not every physician has that ability to go from great clinician to leader, but he took that and without really any prompting. I mean, he just looked at the survey and just ran with it and is created and is creating, extreme change within the college, and, I was happy to see that. It was good to know from my side and good for me to be able to relay back to the students of, "Hey, you've been heard, we're not going to, ignore what you're saying, and there's action happening today."
So, looking back over the decade that Quorum has been up and running, we have spent so much focus on the hands-on, the classroom, the what you're doing in Malta. And with your input, now we're looking at the back end of that as well to improve the student's experience with the emails, with the contact, with direction for what to study and how to study.
Yeah, and I think it's always gonna be a circular kind of pattern that we do, which is good. And I think as we get the back end fine tuned, I can already see the instruction side and the Malta side probably already looking at ways to tighten down also. And I'm sure in, the next couple years we'll be back to the back end side. And so it's the good cyclical process that any institution needs to be doing.
So, Zach, a fortnight ago, we had a chat during the Quorum conversations about setting up ICUs in rough environments in remote and austere areas. Tell us a bit about your experience. You have a profound amount of experience of doing this. So tell us, what have you learned? What are some things we need to know about setting up an ICU in very odd and difficult places?
Yeah, so that's truly where my passion arose for critical care medicine. I was lucky enough that I spent years in the jungles of Central Africa, very much away from any medical system that would compare with the UK or Europe or the US, Canada, any of those. And then I also got to spend a significant amount of time in Southeast Asia. And that's a little bit different, a little bit more built up, but still many of the same principles are going to apply there. And so one of the biggest things is when you go out there, you need to understand your remoteness and how few resources there really are and the extreme measures it takes to get a resource to you. And it's not just distance. Many times it's just it's weather. The rainy season in Africa can take down any possibility of aircraft making it out to you. Um, it's actually quite difficult for that. And so the planning aspect, if you want to be out there, is really where you go from, well, I packed my meds and things like that to now I'm doing a full history on everybody who's going with me. I'm looking at all the different chronic diseases that they have, any medications that they're on, any possible issue with the patients that you might encounter there. Because the reality is things like surgery or even, diagnostics in a lot of these places is non-existent. And so you have to really know that these patients are put on you, and the other aspect is, okay, those are my patients, but now I need to understand my system. And so you have to start looking at reports of the medical facilities that may be within reach. And you may go to some of these and you walk in and you go, "Ooh, I'm not going to allow my team to be treated long term here, but there's still capabilities that they have. And, in Africa, there's a lot of places that do very good microscopy, even in the rural points. And so those may be something that you utilize. Um, and then there's the places where, okay, if I do take someone to surgery, where do they go? And what surgical capability can they actually do in those places? And if you're remote enough, you may be saying, like I was, is if I get a patient out of here, how do I get them out of here? um, you know, 911 or 000 or wherever you're at doesn't quite exist in those places, and the cost of an emergency evacuation is extreme, sometimes up into, 400, 500,000 U. And so insurance is actually one of the things that you request people to get on, to have the travel insurance and to be linked with a company like International SOS, or, not a plug for them. There's many others. I've used them before, but there's many others that are good too. But you're going to want to make sure that you even have that insurance information ready to go. And that way, when you call, because they're not going to start spinning up their partners. Uh, Unless they're going to get paid, or unless your company is gonna just pay the upfront cost of it. So depending, perhaps how big, if you're doing a Nat Geo mission, I'm sure they have, all types of things with them. And another thing is actually, cash on hand. Many places you go to, you don't get the guaranteed emergency treatment that, uh you're going to get if you go in many countries. Emergency, departments will treat you regardless. They're going to do life-saving intervention. Many of these countries, they'll actually put you on a bed and put you on the side and wait for some form of payment, or check your pockets for cash first. And so, even something as simple as that, as bringing cash for every patient to get treatment started, if you need to, even something, as life-saving as a blood transfusion isn't going to happen without payment. And then you get into where you really grow as a paramedic. And I've kind of lined this out with people before, as we're seeing the career field grow. You have advanced paramedics who have this extended pre-hospital scope. But really, when you get into the paramedic practitioner range, is where you start diagnosing and treating things that are really not life-saving, but more encountered microbials and things like that. And so your tropical medicine has to be on point and further understood with the less diagnostic resources you have. And I had many a septic patient uh, due to what we had. And I had traumatic patients also, due to, different, it could have been a motor vehicle accident or whatever had occurred. But the more difficult ones are really those septic patients due to microbials. And some were due to malaria, some were due to these just unknown skin infections that we had. I had one patient with a cephalic presentation of the bubonic plague, which is really rare to see. I mean, that's a minority of bubonic plague patients that you even can see. And you have to be ready to start diagnosing and treating those patients. And, with the best of what you can is getting a clinical picture and treatment plan together, even if you can't treat to its fullest extent, to get that going. And then you're going to encounter things like the wildlife that's out there. The microbials, sure, they may be the wee beasties, but the big beasties are out there also. And snakes were a significant problem. Ran into many boomslangs. We had green mambas. We had puff adders. I mean, we had some of the deadliest snakes around us, and being ready to treat things like that were also a significant part into what you need to look into. And so you really start going from a domain of emergency medicine and opening up to all the domains. And one of the biggest to grasp onto that we're really not taught as paramedics is getting into preventive medicine. If you're at a camp long enough, well, where do you, urinate at? Where do you wash your hands? Where do you how do you deal with trash for food? And there's a lot of things that people don't think of. They'll think of flies, of course, and disease transmission from flies, but flies being frogs and frogs bring snakes, and the flies bring diseases, as everyone's probably already thought in their head too. Or if you have trash out, the trash will bring field mice. The field mice seem to be all over the world, and those field mice bring other snakes and predators and things like that in. And so it's a complex situation that you get yourself into. And you need to be ready to, on the medicine side now, what everyone most wants to focus on is managing a patient and having a full understanding of what is going on with your patient with minimal resources. And even I was lucky enough many a times to have an iStat where I could pull labs that were pretty significant compared to what we're used to. But okay, when you get the labs, what does that mean, and what are you going to do at that point? So yeah, there's so many lessons learned. It was really an educational experience for me through those years, and one of the most profound experiences that really changed my medicine. I would not trade those experiences for anything.
You mentioned the medical intelligence assessment or just doing a map survey before you get there. I remember on the ODAs there in First Special Forces Group, we would have an ADVON, an advanced party, to physically go and look at the local hospitals and the street view you would see of this hospital. Well, we didn't have it back then, but now you can see street view. It might look good, but it might be rubbish. So you do need to have the hands-on, don't you?
You do. Actually, there's many, surgical suites, I'll use that loosely, I walked into that had one particularly had broken tile on the floor, and actually when you walked on it, uh, you could see the dust being kicked up in the sunlight. In the picture of it that was online looked great. It must have been a picture right when they first built it, and that would have been perfect. But at this point, then you get in there and you go, yeah, there's not much I really want my team to get done here. And so at that point, you really have to limit of, well, they have surgical capability, but what's going to be my backstop of depth I allow, because the complications of the dust in the air, what is that going to do? And you have to go look at everything with them. How do they sterilize equipment? How do they store their medications? It's a whole new aspect to get into, and it's very time consuming, and it has a bit of a political sense with it too, in the sense of you're going to assess them, and your people skills and speaking with them have to be good, and have an understanding of what they can do, in what you may need them to do is going to be there too. Because a lot of times, as a Westerner, a physician, or whoever going to these places, they're proud to take you around and show you everything, and they've worked very hard to get the place and the situation as it is, and they don't want you to go in there and tear them down by any means. And so you kind of have to be polite while you're in there, and respect that it may not be perfect, but they're working hard too.
Zach, you mentioned preventative medicine, you mentioned dermatology, you mentioned primary care. It sounds like setting up a jungle ICU, you need to be a jack of all trades.
You do. You need to be a jack of all trades, and that's quite difficult right now. With the way we focus and we do medicine, you don't have jack of all trades. Back in the day, 60, 70 years ago, a primary care physician, many of them would do surgeries, more on the minor side, but they'd still do them. And we don't do that now. If you have, we have entryways to medicine. If you're a general practitioner or family medicine, there's a limit, and then they send you to a specialist. And that's not really the capability that you're going to have there. And I know the saying is, jack of all trades, master of none, but and there's kind of a negative or positive, depending connotation how you look at that. But you're going to have to self-evaluate where your gaps are to be that jack of all trades. And, there's multiple places that can be. I talked about the preventive medicine, the medical intelligence side, the primary care side. But if you're, those exist for if you're a nurse that's going out, you're going to have multiple other sides too. Many of the same, and physicians, you're going to have other sides too. You may be uh, better trained in epidemiology and preventive medicine, or had that because of a rural medicine focus, but the medical intelligence probably wasn't hit on very much. And then, how are you going to perform the lab tests that you would normally just order? Microscopy. How do you do that? What do you use as your mordant and your fixer, and what do you take? What do you not take? Or are you just going to use rapid diagnostic tests? There's a is a it really is it becomes this mountain of a problem, and those that are brave enough will really like it. I mean, I thoroughly enjoyed that I was challenged in multiple ways to make a cohesive medical picture.
Zach, what did you learn on the Masters of Austere Critical Care that addresses some of these issues?
Well, you for sure are going to deep dive into the medicine piece of it, and a lot of times you don't know what you don't know. And I know that's a silly saying, and I used to have a friend which would say, "Of course you don't know what you don't know." But it really opens you up to the vastness of medicine. And within the masters, and allowing you to not just say only read this, but to dive and to wade through the medicine, you start to pull deeper and deeper aspects to bind some of those domains together. As and you also start talking about things like prolonged care and or prolonged field care, whatever, the term you wanna use for it is. And especially within that, you start to see multiple difficulties and realities to it. And there's a whole block on tropical medicine, which I highly recommend. And actually there's a graduate diploma on tropical medicine, which I really recommend through the college. And that, if you've never really looked into tropical medicine, that's going to open your eyes to how much more is out there that you're not familiar with. Much of the temperate medicine, if you're in the US and you say influenza, well, everyone's very familiar with that, even non medical people. But if you start talking about schistosomiasis, one of the many things that's out there, people go, "What?" Well, that's in about every body of water that's out in, the continent of Africa. So now you start to go, oh, it's this whole other domain that I've really not reached into. In With that, you learn the life cycle of diseases, and it starts opening you up into how you can be truly effective there versus just being there and treating emergencies and symptomatically. You break into that practitioner role a bit more.
So, Zach, at the end of this month is SOMA, Special Operations Medical Association's Symposium, one of my favorite weeks of the year. You will be presenting the Medic of the Year scholarship. Can you tell the listener about that?
Yeah, the Medic of the Year scholarship, um, which is great. It's a prestigious award for the medic who gets it. And what they do is, across special operations medics in the U.S., everyone nominates a candidate to be the medic of the year, and there's this committee that picks this individual. And the College of Remote and Offshore Medicine it has a fantastic scholarship that is given to this individual, and I have no clue who it is. I don't think they've released it. I'm sure they hold that very tight. but they get a free scholarship for the Masters of Austere Critical Care program, which is phenomenal. I mean, such a great value to be able to get, uh, and very very neat for the school to honor somebody that way and recognize their ability within medicine and to be able to allow them to go further. So, you know, it's pretty exciting that a school is giving something like that to the awardee.
And you'll be the one presenting it.
Yeah, so yeah, and I will. I'll be the one presenting it. So, um, happy to do it. Happy to keep a good relationship between us and soft medics. I know that's been the college has a pretty rich background of supporting soft medics, worldwide, and especially with your background, that has, of course, been the foundation for that. So I thank you for really starting the culture of that support.
Zach, my final question for you is this. What advice do you have for the new medic, the new nurse, the new doctor who is just starting out in their career in austere medicine?
Mm. I don't know if my answer has changed from the other podcast here. Um, you know, be brilliant at the basics. The basics get you out of trouble that the fancy stuff would have to be employed for. Being brilliant at the basics, if we go back to the domains of, the basics of preventive medicine, the basics of medical intelligence, the basics of primary care and emergency treatment, the basics of all those is what's going to keep you from having to have this outlandish, a treatment plan. And I know some of us, that's kind of what we crave. We want to do those things, but you don't want to do that in the remote environment. A new fear is unlocked when you call for help and nobody's coming, not in any, decent amount of time. So focus on those basics. Look at the basics across all the domains. Wherever your specialty is good at, that's great. Look where it's not good at and make sure that you spend some time there.
Zach, it's fantastic to have you on the podcast again. It's fantastic to have you on our faculty. And thank you for being our guest today.
Absolutely, Aebhric. Thanks for having me on.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.